Chapter 18 Gastrointestinal Alterations. The anatomy and physiology. It begins with the alimentary canal, accessory organs, and especially the gut wall, consisting of the mucosa, gastric mucosal barrier, and submucosa. The oropharyngeal cavity also plays a pivotal role, consisting of things like the mouth, salivary glands, and the pharynx, which then leads to the esophagus. There, the stomach would take over with things like the candida, the body, the antrum, the gastric glands and pyloric glands, as well as the hydrochloric acid. This would then process the food and move to the small intestine, consisting of organs like the duodenum, jejunum, or ileum. And digestion and absorption of foodstuff will begin to take place here, including things like water, electrolytes, and vitamin absorption. Next, you would have the large intestine, including the ascending, transverse, descending, and then the rectum. This is where further water and electrolyte absorption would take place. You'd also have other accessory organs like the pancreas, involved in things like digestive enzymes, insulin, and glucagon, as well as the gallbladder, which stores bile. The liver performs more than 400 functions, though the primary functions are vasculatory and secretory, and it receives 25% of cardiac output. For its vascular functions would include things like blood storage and filtration, while its secretory functions would be bile production as well as bilirubin metabolism. Among its metabolic functions would include things like carbohydrate metabolism, fat metabolism, protein metabolism, production or removal of blood clotting factors, the detoxification of drugs, hormones, and toxins, as well as the storage, synthesis, and transport of vitamin and minerals, such as its storage of vitamins like vitamin A, D, and B12. The superior and inferior mesenteric and celiac arteries supply the stomach, small and large intestines, pancreas, and gallbladder. The liver has a dual blood supply and receives part of its blood supply from the hepatic artery. Circulation to the GI system is unique in that the venous blood draining the system empties into the portal vein, which then perfuses the liver. This portal vein supplies approximately 70 to 75% of the liver's blood flow. During a assessment of the GI history, the patient's questioned about any past problems with indigestion, difficulty swallowing, pain on swallowing, nausea and vomiting, heartburn, belching, abdominal distension, or bloating, diarrhea, constipation, or bleeding. Problems such as anorexia, fatigue, and headache also point to specific GI ailments and should be noted. Weight history includes usual and ideal body weight, along with a history of fluctuations, acute weight loss, and interventions or treatments for weight loss. Pain and assessment can be challenging. The pain receptors in the abdomen are less likely to be localized and are mediated by common sensory structures projected to the skin. Therefore, distinguishing the pain of a peptic ulcer from that of a myocardial infarction is often difficult. Abdominal pain is often caused by engorged mucosa, pressure within the mucosa, distension, or spasm. The nurse obtains a description of the location and the type of pain in the patient's own words. A thorough history of any surgical procedures, including types and dates, should also be discussed, in addition to a current list of medications that the patient is taking. In the case of older adults, changes related to the aging process include decreased salivation, or xerostomia, which is just a fancy word for dry mouth, which may change the patient's taste perception, delayed esophageal and bowel emptying, and increased bowel emptying, which further may lead to anxiety about incontinence, decreased thirst sensation, which may further lead to reduction in fluid intake. There could also be changes in gastric secretions and altered drug metabolism. The most common GI disorder in older adults are functional bowel disorders, such as chronic constipation, irritable bowel syndrome, or peptic ulcer disease. A general inspection of the abdomen focuses on the characteristics of things like the skin color and texture, symmetry, and the contour of the abdomen. This would be in addition to things like masses and pulsations. Further GI assessment, you should auscultate before percussion and palpation. And remember to auscultate for 5 minutes before determining the absence of bowel sounds. In the case of genetics, the cytochrome P540 enzymes, these are pharmacogenetic focus on expressed genomes and drug responses. Pharmacogenetics is the individual variability of genetic inheritance. For PG is the selection of drugs or doses based on that each individual's unique genetic profile. In this case, genes produce 70 to 80% of the enzymes for metabolism of medications. And also, keep in mind to review possible causes of changes in the bowels. Should NA be associated with conditions like decreased or absent bowel sounds, or even increased hyperactive bowel sounds? There can be several causes of GI bleeding, such as the H. pylori or Helicobacter pylori. This is a bacteria that is a major cause of duodenal ulcers. All have high risk of extensive blood loss, and the patient is monitored for hypovolemia and treated accordingly. For stress-related mucosal bleeding or stress ulcers, these are an acute form of peptic ulcer that often accompanies severe illness, systemic trauma, or neurological injury. Ischemia is the prior etiology associated with stress ulcer formation. Ischemic ulcers develop within hours of an event, such as hemorrhage, multisystem trauma, severe burns, heart failure, or sepsis. A Mallory-Weiss tear, on the other hand, is an arterial hemorrhage from an acute longitudinal tear in the gastroesophageal mucosa and accounts for 10 to 15% of all upper GI bleeds. It's associated with long-term nonsteroidal, long-term NSAID use, as well as aspirin ingestion and excessive alcohol intake. The upper GI bleeding usually occurs after episodes of forceful retching. Quick quiz: which over-the-counter medication increases a person's risk for peptic ulcer disease? Would that be A, a multivitamin, B, ibuprofen, C, acetaminophen, or D, probiotic supplements? That answer is going to be B, ibuprofen. NSAIDs inhibit prostaglandins and increase the risk of peptic ulcer disease. In the case of duodenal and gastric ulcers, these are the most common cause of peptic ulcer disease and the most common cause of upper GI bleeding. The ulcer in peptic ulcer disease is a crater surrounded by either acutely or chronically inflamed cells. Over time, the inflamed tissue is replaced by necrotic tissue. You may also be looking at a stress ulcer. This is an acute form of peptic ulcer that often accompanies severe illness, systemic trauma, or neurological injury. Ischemia is the prior etiology associated with stress ulcer formation. Stress ulcers that develop as a result of burn injury are also called curling ulcers. Stress ulcers associated with severe head trauma or brain surgery, on the other hand, are called Cushing's ulcers. A Mallory-Weiss tear. This is an arterial hemorrhage from an acute longitudinal tear in the gastroesophageal mucosa, and these account for 10 to 15% of upper GI bleeds. It is associated again with that long-term NSAID use, or it could be with aspirin and alcohol intake. Esophageal varices occur secondary to portal hypertension. The normal portal venous pressure is 2 to 6 millimeters. As these veins experience increases in pressure, they become distended with blood, the vessels enlarge, and varices develop when the pressure exceeds 10 millimeters. The most common sites for the development of these varices are the esophagus and the upper portion of the stomach. When portal venous pressure reaches 12, the varices tend to bleed. Blood loss should be carefully assessed, along with color, amount, and consistency of the emesis and stool. And this should be monitored closely, along with signs and symptoms of hypovolemia, which can be severe with these bleeding varices. Such symptoms like hypotension, tachycardia, dizziness. Quick quiz: what is the patient at greatest risk for when a GI bleeding is present? That'd be A, anemia, B, hypovolemia, C, infection, or D, increased cardiac output. And that answer is going to be B, hypovolemia, and the patients must be closely monitored for further hypovolemic shock. When would hematochezia occur secondary to upper GI bleeding? And explain why are bowel sounds often hyperactive in GI bleeding. The bright red or maroon blood is usually a sign of a lower GI source of bleeding, but can be seen when upper GI bleeding is massive. The bowel sounds may be hyperactive as the active bleeding is passed quickly through the GI tract. The initial evaluation for the patient with upper GI bleeding involves a rapid assessment of the severity of blood loss, hemodynamic stability, and the necessity for fluid resuscitation, along with frequent monitoring of vital signs and the assessment of body systems for even the slightest sign of hypovolemic shock. An abdominal assessment may also reveal a soft or distended abdomen. Bowel sounds most often are hyperactive as a result of the sensitivity to the bowel to blood. An endoscopy is the procedure of choice for the diagnosis and treatment of active upper GI bleeding and for the prevention of rebleeding. The endoscopy allows for a direct mucosal inspection with the use of a flexible fiber optic scope. The procedure can be done at the bedside, which is an advantage when caring for a critically ill patient. Endoscopic evaluation of the source of the bleeding is usually not undertaken until the patient is hemodynamically stable. Barium studies can be performed to help define the presence of peptic ulcers, the sites of bleeding, the presence of tumors, and the presence of inflammation. Patients who are hemodynamically unstable need to have immediate venous access using large bore intravenous catheters, and the administration of fluid is started. Gastric lavage used to treat upper GI bleeding, or before endoscopy for acute upper GI bleeding, is safe and provides better visualization of the gastric fundus. A large bore NG tube is inserted and is connected to suction. If lavage is ordered, 1,000 to 2,000 milliliters of room temperature normal saline is instilled via the NG tube and is then gently removed by intermittent suction or gravity until the secretions are clear. Ice lavage is also used in some centers, although the evidence for this is not well documented. After lavage, the NG tube may be left in or removed. NG tubes left in place may increase hydrochloric acid secretion in the stomach and cause increased further bleeding. Pharmacologic agents are given to decrease gastric acid secretion or to reduce the effects of acid on the gastric mucosa. The most common agents used include antacids, histamine antagonists, proton pump inhibitors, or mucosal barrier enhancers. Antibiotics may also be ordered in the case of H. pylori infection, and is often associated with peptic ulcer disease. A triple agent therapy with a proton pump inhibitor and 2 antibiotics for 14 days is the recommended treatment. Sclerotherapy involves injecting the bleeding ulcer with a necrotizing agent, while thermal agents of an endoscopic therapy include the use of heater probes, laser photocoagulation, or electrocoagulation to tamponade and sear off and close that vessel. Endoclipping may also be used with band dilators and hemoclips to provide hemostasis and decrease the incidence of rebleeding. For surgical treatment, there could be various different types, such as a gastric resection, a Billy-Roth 1 or 2, a vagotomy, or a pyloroplasty. Several nursing diagnoses are associated with the postoperative care of the patient with upper GI bleeding. These diagnoses include risk for infection of wound, peritoneum, or both. Altered nutrition, pain, fluid and electrolyte alterations, or even impaired gas exchange may also be present. Changes in blood pressure and heart rate depend on the amount of blood loss, the suddenness of the blood loss, and the degree of cardiac and vascular compensation. Vital signs should be monitored at least every 15 minutes. As blood loss exceeds 1,000 milliliters, the shock syndrome progresses, causing decreased blood flow to the skin, lungs, liver, and kidneys. Hypotension is an advanced sign of shock. As a rule, a systolic pressure of less than 100 millimeters, a postural decrease in blood pressure of greater than 10 millimeters, or a heart rate of greater than 120 beats per minute reflects a blood loss of at least 1,000 milliliters of the total blood volume. Somatostatin, or octreotide, is commonly ordered to slow or stop bleeding. Early administration provides for stabilization before endoscopy. These drugs decrease blood flow and reduce portal pressure and have minimal adverse effects. 3 types of tubes are used for a tamponade: a Sengstaken-Blakemore tube, a Minnesota tube, or a Linton tube. In addition to the sclerotherapy we previously discussed, the transjugular intrahepatic portosystemic shunt, or TIPS, is a non-surgical treatment for recurrent bleeding. It's performed under fluoroscopy, and a stent is placed between the hepatic and portal veins to reduce that portal pressure. Quick quiz: a portocaval shunt is done to prevent variceal bleeding. This surgery is associated with what negative outcome? A. Acute kidney injury, B. Ascites, C. Encephalopathy, or D. Gastric ulcer? And that answer is going to be C. Encephalopathy. Acute pancreatitis is an inflammation of the pancreas with a potential for necrosis of pancreatic cells resulting from premature activation of pancreatic enzymes within the pancreas. Acute pancreatitis has numerous causes, but the most common are alcohol ingestion and biliary disease. Numerous drugs may initiate acute pancreatitis as a result of either ingestion of the toxic doses or a drug reaction. Pancreatitis resulting from blunt or penetrating abdominal trauma or occurring after endoscopic exploration of the biliary tree has also been reported. The most common theory regarding the development of pancreatitis is that an injury or disruption of pancreatic acinar cells allows leakage of the pancreatic enzymes into the pancreatic tissue. The leaked enzymes become activated in the tissue and start the process of autodigestion. The activated enzymes break down tissue and cell membranes, causing edema, vascular damage, hemorrhage, necrosis, and fibrosis. The classic signs and symptoms is going to be severe pain, with epigastric or mid-abdominal radiating to the back. There may also be present with nausea and vomiting, abdominal distension, ascites and jaundice, and retroperitoneal hemorrhage. There are many different diagnostic tests and imaging that can be done, ranging from CT, MRI, ultrasound, and even X-ray. When treating with fluids, the IV solution ordered for fluid resuscitation is usually colloids or lactated ringers. However, fresh frozen plasma and albumin may also be used. IV fluid administration with crystalloids at 500 milliliters an hour is at times required to maintain their hemodynamic status. Volume replacement is guided by hemodynamic assessment as well as the patient's lab values. Hypocalcemia is a common electrolyte imbalance. In the case of severe hypocalcemia, this may cause tetany, seizures, positive Fostex and Trousseau sign that we discussed in the last term, as well as respiratory distress. On the other hand, patients with severe hypocalcemia should be placed on seizure precautions and have their respiratory support equipment readily available. Hypokalemia can be associated with cardiac dysrhythmias, muscle weakness, hypotension, decreased bowel sounds, and the potassium must be diluted and administered via an infusion pump per unit protocol. Remember, we always go very slow with our electrolytes, but especially in the case of potassium. For surgical treatments, we're going to be focused on the decompression for retroperitoneal edema, ascites, ileus, and overaggressive fluid therapy. The decompression of abdominal compartment syndrome, or ACS, is defined as intra-abdominal pressure greater than 20 millimeters with new onset organ failure. ACS is present in about 60% of patients with severe acute pancreatitis. In the case of nutrition, a NG tube may be ordered and the patient may be kept NPO. However, trends in nutritional management are changing. Early nutritional support may be ordered to prevent atrophy of gut lymphoid tissue, prevent bacterial overgrowth in the intestine, and increase intestinal permeability. Immediate oral feeding in patients with mild acute pancreatitis is safe and may accelerate recovery. Systematic reviews of early enteral nutrition for severe acute pancreatitis were done to evaluate its effectiveness and safety. Pain control is another nursing priority in patients with acute pancreatitis, not only because the disorder produces extreme patient discomfort, but also because pain increases the patient's metabolism and thus increases pancreatic secretions. Adequate pain control requires the use of IV opioids, often in the form of patient-controlled analgesia pumps or PCAs. In the case in which a PCA pump is not ordered, pain medications are administered on the routine schedule rather than as needed to prevent uncontrollable abdominal pain. Traditionally, opioid analgesics like morphine were considered to cause spasm of the sphincter and exacerbate pain. However, current research questions this practice. Several complications associated with severe pancreatitis include multi-system organ failure, such as issues with cardiovascular, GI, hematologic, metabolic, pulmonary, and renal systems. Branson's criteria is one way to predict mortality. Patients with acute pancreatitis can develop mild or fulminant disease. As a consequence, research has addressed criteria for predicting the prognosis of patients with acute pancreatitis. The early classification criteria were developed by Branson, where the number of signs present within the first 48 hours of admission directly relates to the patient's chances of significant morbidity and mortality. In Ranson's research, patients with fewer than 3 signs had a 1% mortality rate. Those with 3 to 4 signs had a 15% mortality rate, and those with 5 or 6 signs had a 40% mortality rate. and those with 7 or more signs unfortunately had a 100% mortality rate. Nursing interventions focus on pain management, preventing hypovolemic shock, ensuring nutrition, and preventing complications. Everything from controlling pain and promoting comfort, preventing and treating shock, maintaining nutrition, and minimize any and all complications. Quick quiz. A patient presents with acute jaundice, chills, fever, lethargy, nausea, and vomiting after returning from a trip abroad. She shares she was sexually active with several partners on the trip. Which hepatitis virus may the patient have been exposed to causing these symptoms? That be hepatitis A, E, C, or B? And that answer is going to be hepatitis B. Risk from sexual contact is possible when exposed to viral strains, B, D, or G. Hepatic failure can occur due to many different issues, everything from hepatitis, decreased perfusion, cirrhosis, or fatty liver disease. Hepatitis is an acute inflammation, often accompanied by edema. It may also result in portal hypertension. It's most often caused by a virus, the hepatitis virus. And in such as the case of hepatitis A, it could be from the fecal oral route, or in the case of hepatitis B and C, it could be the sexual or IV drug use, blood exposure route. The symptoms of hepatitis are GI pain, fever, chills, jaundice, brown urine, bright upper quadrant pain, and clay-colored stools. Patients with hepatitis are often asymptomatic, and in many patients, there could be prodromal symptoms of anorexia, nausea, vomiting, abdominal pain, and fatigue that may be present. Symptoms then progress to a low-grade fever, an enlarged tender liver, and jaundice. No definitive treatment for acute liver inflammation exists. The goals for medical and nursing care include providing rest and assisting the patient in obtaining optimal nutrition. Maintenance of the nutritional status of the patient is a nursing priority, and the loss of appetite, nausea, and vomiting may persist for weeks. Nursing measures such as administration of antiemetics may be helpful, as well as small, frequent, palatable meals and supplements that should be offered. Alcohol should also be avoided. Special precautions should be taken to prevent spread of the virus when caring for patients with hepatitis. These include the use of universal precautions when handling all items that are contaminated with the patient's body secretions, and including the patient care items such as thermometers, dishes, and eating utensils. In some cases, a liver transplant may be necessary due to refractory irreversible liver disease. The postoperative complications focus on bleeding, as well as infection, rejection, and fortunately, a liver donation may be from a live or deceased donor. In the case of living donors, they can actually donate one lobe of their liver, and because the liver has such a great ability to regenerate, both livers would regrow into full functioning livers. Cirrhosis is the destruction of liver parenchyma and the replacement by scar tissue. It causes severe alterations in the structure and function of liver cells, and is characterized by an inflammation of the liver cell necrosis that develops. It may be focal or diffuse, along with fat deposits that may also be present. The enlarged liver cells cause compression of the liver lobule and lead to an increased resistance to blood flow and portal hypertension. Necrosis is followed by regeneration of liver tissue, but not in a normal fashion. Fibrous tissue is laid down over time, and this distorts the normal architecture of the liver lobe. These fibrotic changes are usually irreversible, resulting in chronic liver dysfunction. The term fatty liver refers to an accumulation of excessive fats in the liver, and it is morphologically distinguishable from cirrhosis. Most common causes are unrelated to alcohol use and can result in the development of what's termed non-alcoholic fatty liver disease. The causes of this entity include obesity, diabetes, hepatic resection, starvation, and total parenteral nutrition. The damage caused by the fat deposits may result in liver dysfunction, liver failure, or even death. The initial clinical signs of hepatic failure are vague and include weakness, fatigue, loss of appetite, weight loss, abdominal discomfort, nausea and vomiting, and a change in bowel habits. As the destruction of the liver progresses, the systemic effects of the disease become apparent. Impaired liver function results in a loss of the normal vasculature, secretory, and metabolic functions of the liver. And the functions of the liver disease are divided into three categories: portal hypertension, impaired liver metabolic processes, and impaired bile formation. In the case of portal hypertension, there are two clinical problems that develop: the hyperdynamic circulation and the development of esophageal and gastric varices. Liver cell destruction causes shunting of blood and increased cardiac output. Liver failure causes the altered carbohydrate, fat, and protein metabolism, decreased synthesis of blood clotting factors, a decreased removal of activated clotting components, decreased metabolism of vitamins and iron, a decreased storage functions, and a decreased detoxification functions. The liver's inability to metabolize bile is reflected clinically in an increased serum bilirubin level and a staining of tissue by bilirubin or jaundice. Jaundice is generally present in patients with serum bilirubin levels greater than 3. Initial clinical signs of hepatic failure are vague and include weakness, fatigue, loss of appetite, weight loss, abdominal discomfort, nausea and vomiting, and a change in bowel habits. As destruction in the liver progresses, the systemic effects of the disease becomes apparent. Impaired liver function results in a loss of the normal vascular, secretory, and metabolic functions of the liver. The administration of vasoactive drugs and fluids may be ordered to support blood pressure and kidney perfusion. Hypoglycemia is common in liver failure, and it's caused by a depletion of hepatic glycogen stores and the loss of ability for glucogenesis. The patient with liver failure is at risk for bleeding complications because of decreased synthesis of clotting factors. In some cases, a bioartificial liver device can serve as a bridge to liver transplantation or to support liver function long enough to allow regeneration of normal liver function. The bioartificial liver circulates the individual's blood around the outside of a system of hollow fibers packed with pig hepatocytes to allow toxins to be removed and nutrients to be replaced. Another type of support is the molecular absorbance recirculating system, or MARS. It's an extracorporeal albumin dialysis technique that uses an albumin-impregnated membrane to remove both the protein-bound and water-soluble toxins from the blood. Ascites, as we've previously discussed, that is the large edema collecting within the abdomen, and it can be due to low albumin plus obstruction to flow, just fluid within the peritoneal cavity, increased aldosterone such as sodium and water retention, and the peripheral edema causing further ascites. The impaired handling of salt and water by the kidneys and other abnormalities in fluid homeostasis can predispose the patient to fluid accumulation within the peritoneum, or ascites. Ascites is medically managed through bed rest, a low-sodium diet, fluid restriction, and diuretic therapy. Diuretics must be administered cautiously, however, because if the extravascular volume is depleted too quickly, acute renal failure may be induced. Paracentesis, in which the acidic fluid is withdrawn through a percutaneous needle aspiration, is another medical therapy for ascites. The close monitoring of vital signs during this procedure is necessary, especially as fluid is withdrawn. Albumin may be administered to increase colloid osmotic pressure and to decrease loss of fluid into the peritoneal cavity. Other options, such as shunting, is a surgical procedure used to relieve ascites that is resistant to other therapies. The Levine shunt is inserted by placing the distal end of the tube in the peritoneum and tunneling the other end under the skin into the jugular vein or superior vena cava. A valve that opens and closes according to pressure gradients allows the acidic fluid to flow into the vena cava. The nursing assessment would include assessing the respiratory rate, breath sounds, and pulse oximetry values. Frequent monitoring of that abdominal growth also alerts the nurse to any additional fluid accumulation. Positioning the patient in a semi-Fowler position also allows for free diaphragm movement, as well as frequent deep breathing and coughing exercises. Some patients may require elective intubation until medical management of the ascites is accomplished. Quick quiz. What is hepatic encephalopathy caused by? Would that be A, increases in ammonia, B, decreases in calcium, C, increases in potassium, or D, a decrease in sodium? And that answer is going to be A, ammonia. In the case of portal systemic encephalopathy, this is commonly known as hepatic encephalopathy, and is a functional derangement of the central nervous system It causes altered levels of consciousness and cerebral manifestations ranging from confusion to coma, as well as motor ability that may also be impaired. The exact cause of hepatic encephalopathy is unknown, but it is thought to be abnormal ammonia metabolism, increased serum ammonia levels that interfere with normal cerebral metabolism, as well as esterixis, a flapping tremor of the hand, being an early sign of hepatic encephalopathy that can be assessed by the nurse. Another quiz. What is the term for flapping tremors seen in hepatic encephalopathy? That be A. Chvostek's sign, B. Cullen's sign, C. Esterixis, or D. Trousseau's sign? And that answer would be C. Esterixis. Medical management of encephalopathy would take many different forms, everything from lactulose that causes ammonia elimination via the colon, and that it will bind to the ammonia and help pull it out of the GI tract. Also, working to restrict toxic medications, dietary protein restrictions that could possibly be no longer indicated depending on the facility, as well as a judicious use of analgesia and sedation due to the altered mental status of these patients. In the case of acute renal failure that occurs with liver failure, this is called hepatorenal syndrome. And the pathophysiology of this disorder is not well understood, but it is associated with end-stage cirrhosis and ascites, decreased albumin levels, and portal hypertension. HBS is a pulmonary complication that's observed in patients with chronic liver disease, portal hypertension, or both. HBS occurs because of intrapulmonary vascular dilation that may induce severe hypoxemia. HBS is defined as a triad of liver disease, increased alveolar arterial oxygen gradient, and intrapulmonary vascular dilations. Patients with HPS experience hypoxia as a result of ventilation perfusion mismatch, pulmonary capillary vasodilation, and limitations of oxygen diffusion. Pulse oximetry and arterial blood gas measurements are useful screening tools for HPS. Current medical and surgical therapies include oxygen and TIPS, as well as liver transplantation being the definitive treatment to improve symptoms and survival. The nurse's scope of care includes ongoing assessments and monitoring, documentation and reporting of patient responses to diagnostic and treatment regimens, early detection of complications and supportive care, patient and family teaching of the ICU routine and all therapies instituted is also a priority. Successful management of all these patient populations requires a collaborative effort of all disciplines. Liver failure often causes complications for all body systems, and this is going to take a wide range of effects on the body, everything from cardiovascular, neurologic, pulmonary, metabolic, renal, and even the integumentary system. For our key points, the GI system is complex, and the functions are influenced by neural and hormonal factors. Also, acute GI bleed has several etiologies, but the initial treatment priorities are the same: hemodynamic stability and isolate the cause of bleeding. And finally, viral hepatitis has numerous cases and differing severity of liver injury. Liver failure management is often considered supportive, and liver transplant often indicated for diverse causes of liver failure and as the only true, real cure and correction. The complications with liver failure can be widespread and multi-system: cardiovascular to pulmonary to neurologic to GI to hematologic. But anyway, that's all we got for these slides. I'll see you in the next chapter.